That heart attacks don't just begin suddenly in the heart. Heart attack is the end result of things changing in our body earlier. They begin quietly, years earlier, and in the way the body handles your blood sugars, the insulin, the stress, inflammation. All those things add to the risk of heart attack. So long before someone has a chest pain or a blocked artery, the metabolism is already under strain. Inflammation quietly damages the blood vessels, and stress hormones are elevated. So there's a lot of metabolic changes that are happening in the body. By the time you get the heart attack, that is the scream that you end up getting. The damage has been building up for a decade or sometimes even longer. And many people who suffer the heart attack never had high cholesterol to begin with by the traditional standards. So you could have a completely normal cholesterol and still get a heart attack because you might have underlying metabolic disease that was never diagnosed. Our system is built to diagnose disease. We are so disease-centric. We don't treat how to detect risk early. And there's no ICD codes for that. The health system is such that for a busy doctor's office, you need to have a diagnosis of the problems. As a doctor, after working for 20 years, I noticed that the same pattern happens, and we observe that again and again. People didn't suddenly get sick. Their bodies had been changing quietly for years, but no one warned them, and no one explained what those early changes meant. The other thing I noticed was the heart attack, the strokes, dementia, cancer, they begin silently decades early. By the time the symptoms appear, the biology has often been drifting for the previous 10 to 20 years. The subclinical changes are happening in your 40s and 50s. So just because your doctor said your labs are normal doesn't mean everything in your body is okay.
Welcome back to Lower the Dose Season 1, Diabetes and Metabolic Wellness. Today we're talking about something most people never connect to their blood sugar: heart attacks. We usually think of heart disease as a cholesterol problem or a cardiologist's world. But what if the very first signs of a future heart attack show up in your metabolism long before they even ever show up in your arteries? A super important topic. Excited to dive into this with you. Hi, Dr. Rangi. How are you today?
I'm doing good, Lela. Good to see you again. Wish you a Happy New Year.
Happy New Year. Nice to see you again. Starting off the new year, getting healthy, paying close attention to our health. And I know that you've said this before, but you've mentioned by the time the heart screams, the metabolism has been whispering for years. And I think that's such a such a powerful statement. So what does that mean exactly when you say that?
Leila, what that means is that heart attacks don't just begin suddenly in the heart. Heart attack is the end result of things changing in our body earlier. They begin quietly, years earlier, and in the way the body handles your blood sugars, the insulin, the stress, inflammation. All those things add to the risk of heart attack. So long before someone has a chest pain or a blocked artery, the metabolism is already under strain. The blood sugar spikes can happen if somebody has diabetes. They have insulin resistance. Inflammation quietly damages the blood vessels, and stress hormones are elevated. So there's a lot of metabolic changes that are happening in the body, and that leads to the end result of heart attack. Those are the whispers that I was talking about. And by the time you get the heart attack, that is the scream that you end up getting. The damage has been building up for a decade or sometimes even longer. In fact, that concept is the foundation of my book that I'm writing. It's called The Silent Decade. It's coming out in April, and I'm really excited because I'm talking about exactly the same topic: how our metabolism and changes that happen in our body that are silently hurting us 10 years before the disease shows up. When the body is giving those subtle signals, but we didn't hear those whispers, what can we do? How can we catch it early? And how can we prevent it from happening? Because we've not been
That's so
taught.
important.
Yeah, because we've not been taught how to listen to that. The traditional medical system is made in such a way we usually wait for the disease to happen. And we need to, again, think upstream, think proactively understand who is at a higher risk for a heart attack so that we can start working with them 10 years, 20 years before that can happen.
Absolutely. It's so important for people to notice these warning signs early on because it's so often that people don't know these warning signs at all. And then they get to a point where it's, we previously spoke about in a previous episode about trying to get into remission versus being able to really prevent it. So those warning signs are so important to be aware of. And I know you probably deal with this a lot with your patients, but a lot of patients say, my cholesterol was fine. How did I get a heart issue? How did this happen? So when you do come across patients like that, what do you tell them?
Layla, I tell them very honestly that cholesterol is never the full story. That's just part of the equation. Cholesterol is one risk factor, but the heart disease is a metabolic disease first. And many people who suffer the heart attack never had high cholesterol to begin with by the traditional standards. So you could have a completely normal cholesterol and still get a heart attack because you might have underlying metabolic disease that was never diagnosed. So what they have often for years is insulin resistance and the blood sugar instability, where your blood sugar start going up over time because of metabolic overload. They can have visceral belly fat. They can have visceral is around the organs. Um, or inside the organs. So that is what causes more insulin resistance, and that is more associated with heart disease. It's not the subcutaneous tissue or the subcutaneous fat that you can feel when you pinch the skin, but it's the fat that is around your organs inside the body. And that causes not only the insulin resistance, but chronic low grade inflammation. So insulin resistance damages the lining of the blood vessels. It creates oxidative stress and inflammation, and that leads to endothelial damage. Endothelium is the inner lining of the blood vessels. And when they get damaged, the cholesterol sticks more easily, and that becomes more dangerous. So cholesterol isn't the starting point. It's often the secondary player in much bigger metabolic process that began years earlier.
Wow. And what are the earliest metabolic signs that someone is headed towards some sort of heart trouble, even if they're feeling okay and they feel fine?
Yeah, the earliest signs are rarely dramatic. They're very, very subtle. And that's why we often miss them. And especially when you do just one yearly physical or exam, we are basically looking at blood tests to see everything is normal. We're not looking through that picture of looking for subclinical problem, things that are not obvious yet. What else could be going on? So these are gradual increase in your waist size, even though your weight gain may not be there, but the waist size circumference can increase. You may notice fatigue or tiredness after eating. You may notice cravings for sugar or carbs, especially in the afternoons and evenings because of your constantly high cortisol or high imbalance in your hormones. Some people feel brain fog or poor concentration. Some people have poor sleep. Sleep apnea goes undiagnosed for a long time. So there are a lot of people who have either challenges with snoring, or so they're always tired when they wake up in the morning because they did not get enough quality sleep. Their rising glucose might start going up a little bit, and they can also have an A1C that is higher than normal, or the hemoglobin A1C, the number that we use to diagnose as prediabetes, if it is between 5.7 to 6.5, and if it's more than 6.5, we diagnosed as diabetes. So that can start trending up. And we also notice some people can have elevated triglycerides or low HDL. Those are types of cholesterol that we monitor. So these are not random complaints. They're early metabolic warning signs that we see quite common, and the body is becoming insulin resistant and inflamed, and often 10 to 20 years, a decade or longer before the heart event happens. So if you try to listen, if you try to understand, there are subtle signs that happen. And this is exactly what the silent decade refers to, a long window where the disease process is active, but it is invisible. We also call it as a subclinical stage before it becomes obvious and clinical. So hope that helps.
Absolutely. And speaking about that, why do you think that traditional medical systems sometimes miss these early clues for 10, even sometimes 20 years?
That's because our system is built to diagnose disease. We are so disease centric. Our medical system is such. In medical school, we teach how to diagnose disease and how to treat it. We don't treat how to detect risk early. Um, and there's no ICD codes for that. The health system is such that for a busy doctor's office, you need to have a diagnosis of the problems. And
Mhm.
the system is such that we got to step outside the system to understand how is my body functioning and what can I do to not get that disease that when eventually we will be looking for treatment, but we need to look for 10 years before the disease, which way I'm heading. So we wait for numbers to cross diagnostic threshold. That's one of the reasons why traditional medical system misses the early clue 10 years prior. And diabetes instead of insulin resistance, hypertension instead of rising blood pressure. If you check blood pressure in the office once or twice a year, you may not catch that blood pressure that has a tendency to stay high at home. And we're looking for blocked arteries that are giving symptoms of chest pain or difficulty with walking if it's a peripheral vascular system, instead of looking for endothelial dysfunction or looking for the function of inner lining of the blood vessels. So most routine checkups, they don't measure insulin. They do not measure inflammation. They do not measure glucose variability. They do not measure the visceral fat. That's why in our practice, we do body composition analysis to look at how much visceral fat somebody has. We also like to look at continuous glucose monitor. We like to use more technology as much as we can. We like to use Aura Ring to look for the sleep pattern and to look for how much resting heart rate somebody has. So those are all the devices or the biomarkers and we can use to map somebody's health and the risk factors. They don't look at the pattern over time in the traditional medical system, but what we do in our practice is we look at how the pattern is changing over time. Also we are working in silos. I don't know how you feel about it, but I personally feel, there's separation in medicine. Cardiology focuses on you got to have a heart problem before you go to cardiologist. And once you have the blockages, endocrinology focuses on hormones and metabolism. And but the heart problem started with the metabolic dysfunction that as an endocrinologist, I got to catch that 10 or 15 years before somebody got prediabetes or diabetes. But by the time I get the patient referred, they have the diagnosis of diabetes or prediabetes. So very much so, I should have seen those patients 10 to 20 years before they came to me first. And that's what I encourage in my practice. That start looking at your risk factors. Let's start working with you before you develop the diabetes, before you develop prediabetes, before you develop any disease. So we can look at your risk factors and your biomarkers, and we can help you reverse those. So we can map your health, so we can design your health so you don't get those complications.
Absolutely. And with heart disease, you often say that it starts with insulin, not cholesterol. So, can you explain that in simple terms?
Yeah, insulin is a hormone. One of the things that I also wanted to mention was people think the hormones are just the sexual hormones. There's so many other hormones in the body as well. So when we talk about metabolic imbalance or hormone imbalance, that includes a lot, not just your fertility or sexual health or just the female hormones or testosterone in men. It is even insulin is a hormone. So this helps move sugar out of your blood into the cells. And when the cells become resistant to insulin, which happens with excess sugar intake or with visceral fat, inactivity, more sedentary lifestyle with stress, the body compensates by making more insulin. And that is a situation when we call it hyperinsulinemia. And high insulin and insulin resistance, they both cause damage of the blood vessels. They reduce the nitric oxide, which keeps the arteries flexible. They increase inflammation and oxidative stress. and they create abnormal lipid patterns or the cholesterol, even if the cholesterol looks normal. So insulin resistance sets the stage, and cholesterol just plays its role inside the damaged environment. So we want to work with people before we even look at the cholesterol. They have a lot more metabolic imbalance going on that we need to help them with.
How do belly fat and sugar swings and stress combine into what you call cardiometabolic overload?
Yeah, this is one of the most important concepts to understand. Belly fat, especially the fat that is inside the organs or around the organs, is not passive. It is metabolically active tissue that releases inflammatory markers or chemicals that directly attack or affect the bloodstream, especially in the liver. Sugar swings, or if you have high blood sugar and then you drop in blood sugar, they create repeated oxidative stress in the blood vessels and damage the blood vessels. And these glucose spikes are often more damaging than mildly elevated blood sugar all the time. So we often talk to people about importance of keeping their blood sugars in range or time in range or TIR. We recommend that to be more than 70% and if possible, 80% or 90% or 100% of the time. And the recommendations are to get hypoglycemia less than 3% of the time, out of which severe hypoglycemia less than 1%. So these are the guidelines that have been created by American Diabetes Association for people who are wearing continuous glucose monitors. So we like to prevent sugar swings and try to keep them more time in range. And these glucose spikes are, like I said, are often damaging the blood vessels. Then comes chronic stress. Chronic stress raises our cortisol, and that worsens the insulin resistance, that promotes more fat storage or in the belly, and increases inflammation and does influence our sleep and recovery both. So together, these create a vicious cycle. You have visceral fat that causes more insulin resistance, that causes more glucose instability, that causes more inflammation and more fat and more stress. So this cycle overwhelms the body's ability to compensate. And I call that cardiometabolic overload, the true setup for heart disease during the silent decade. And there are ways to handle this. And we definitely work with people to help understand what are their risk factors and how can we decrease their cardiometabolic overload so they can prevent heart attack and stroke.
Absolutely. And what are three surprising clues someone's heart might be at risk, or clues most people would never even really associate with heart disease?
I think one of the very common ones is fatigue, especially more prominent after eating. That's not just aging. It's a blood sugar dysregulation or insulin resistance that is causing fatigue after meals. Then increasing waist circumference in spite of normal body weight. Your belt size is often a better predictor of heart risk than your scale. And the third is poor sleep or snoring. Sleep disruption worsens insulin resistance, inflammation, and your blood pressure. In people with sleep apnea, their blood pressure can improve much better if they have better sleep. Instead, what happens is they end up getting blood pressure medications one after the other, and their sleep apnea never gets addressed. So, poor sleep and snoring dramatically increase your heart risk as well. These are all three of these that we just talked about. These are not heart symptoms, but they're early metabolic warning signs that appear years before the cardiac event happens.
When we talk about early heart risk, what labs reveal heart risk early on, even when cholesterol may look normal?
Leila, I like to look at the other inflammatory markers before some disease has established or happened. We like to look at the C-reactive protein. We like to look at fasting insulin, A1C trends, how they are going over time, triglyceride to HDL ratio. We like to look at advanced lipid patterns. We like to look at other metabolic markers, things that can give us subtle answers to things that have been happening. I also like to do sleep study in people who I suspect to be at a higher risk. So yeah, and we also offer, like I said, body composition analysis to look for visceral fat. And in some cases, if they have abnormal liver test, we also like to get fibroscan to understand how their liver is. And sometimes we notice people with fat in the liver, they progress to liver failure. In the past, we used to say alcohol was the most common toxin or the cause for liver failure. And now we say non-alcoholic fatty liver disease, or fat acts as a toxin for our liver, and that increases the risk of liver failure. So we do whatever we need to do based on individual person, instead of doing just the same labs on everyone. If somebody's got a family history, I might check lipoprotein A. I might look for homocysteine. I might look for other tests that will help me help that person specifically.
Well, and if someone is listening right now and thinking, wow, this sounds like me, something here is standing out that is making me self reflect and sounds like me, what's the first step that they can really take even this week to start protecting their heart?
I think they can one focus on walking at least 150 minutes or activity 150 minutes a week. And if they just cannot do that, make sure you walk 10 minutes after your meals. That is the least you can do. Don't have any added sugars. Do not have any liquid sugars, things that you drink in sodas and sugar juices and things like that. And you can consider having protein first when you eat your meals before having carbohydrates.
Interesting. And what are three of the biggest levers that someone can pull to really reverse metabolic heart risk?
If somebody has prediabetes, we should try to reverse that. If somebody has diabetes, we should try to normalize it and lower it as much as possible. So basically, stabilizing your blood sugars is the most important thing we can do. Now, if somebody does not have prediabetes or diabetes, they may have metabolic syndrome. And in that case, we still need to make their metabolism much more in balance. Reduce chronic stress, start prioritizing your mind. I totally believe in mindfulness and doing whatever it takes to prioritize your mind so you're not constantly getting pulled in every direction without looking at yourself as most important person in life. Improve the sleep. Chronic inflammation through nutrition and movement. Get on anti-inflammatory diet, work with a nutritionist. And that's why in our practice, we offer holistic approach for this, because we know most people could be in silent decade that we can catch before they can get a heart attack. So we have nutritionists we work with. We have a wellness coach. We have patients that we evaluate and then create a program for them. And based on the risk factors, it could be a 30 days, 60 days, or 6-month program to change their course of the disease or their risk factors. And during that 6 months, they work with our wellness coach, nutritionist, and movement coach, and mindfulness. So we try to give it as much holistic approach as possible. And those are the biggest things to help reverse the metabolic heart disease risk. We don't need perfection. We just need consistency. We just need to make sure that whatever we do it with that goal of not getting that first heart attack, not just thinking about today that my blood sugars are okay and I'm fine and I don't have this complication. But we want to talk and have a discussion with our doctors and say, what are my risk factors for the complications down the road? How can I personally take care of myself to decrease the risk of those complications and do it consistently?
Absolutely. And why do you believe that endocrine and metabolic medicine should be at the center of heart disease prevention?
Like I mentioned earlier, the heart disease does not begin in the heart. That is the end result. It begins in your metabolism. So, way before you need to see a cardiologist, you got to work with your primary care doctor or with your endocrinologist to decrease your risk of metabolic complications. So you don't even have to see a cardiologist, and you can reverse those metabolic complications. Now, also because metabolic medicine, as an endocrinologist, I also deal with middle-aged women and men. If you're going through menopause and if you have a drop in your estrogen over time, that adds on to your metabolic risk. Menopause is a time when people have more risk of weight gain. And that is a common frustration among my friends because they get more belly fat. And we need to assess who's the right patient so we can place them on hormone replacement therapy. People are more afraid of hormone replacement therapy than what they understand about their risk of not being on hormone replacement therapy. So you need to have that dialogue and discussion with your doctor and understand what are your specific risk factors. And there's so much that as an endocrinologist we can do with their metabolic health and hormone health, optimize those two so people don't even have to have um, heart disease.
Absolutely. And we spoke about this on our previous episode about focusing upstream. So, if the medical system truly focused upstream, what do you think heart disease care really could look like?
I call it 4 Ps: preventive, proactive, taking steps to take the action, not just talking preventive; personalized, taking individual risk factors and addressing those; and more personalized and precision based. Sorry. So, what I like to do in my practice is we often see people who have had their parents get a heart attack in 70s or 80s, and these children are already getting stents when they're in their 50s or 60s. So, we are seeing heart disease happening 2 decades before their parents had it. And they often say, well, it runs in my family, but it runs in your family, but something made you get it 2 decades sooner. So we really want to work with them in a way so we can prevent that event from happening. And if somebody's really going to get it, then that heart disease does not happen till late in their life, not earlier. So I think to me, that is the center of heart disease prevention. Work with individual risk factors, work with individual um, and use the precision based markers to understand what could be the absolute risk of somebody that we otherwise don't know.
Absolutely. And Dr. Rangi, I know you mentioned earlier in the episode about writing your book that's coming out this April. So, can you tell us a little bit more about why you decided to write it and what people can really expect to learn from it?
Yeah, Layla, as a doctor, after working for 20 years, I noticed that the same pattern happens, and we observe that again and again. People didn't suddenly get sick. Their bodies had been changing quietly for years. But no one warned them, and no one explained what those early changes meant. The other thing I noticed was the heart attack, the strokes, dementia, cancer, they begin silently decades earlier. And there's some commonality to that. By the time the symptoms appear, the biology has often been drifting for the previous 10 to 20 years. So the book is basically about that invisible phase when we could do something to prevent these life limiting diseases that eventually happen. There's a lot to understand how insulin resistance can be a common denominator for these 4 major life limiting diseases that people can expect around the time and time. Those are the times when you start noticing aging changes, and you talk about getting tired easily, but those are result of metabolic changes for decades before that. So I don't think it's very wise for people to learn all this in their 80s and 90s. They got to start working early. You got to start the changes. The subclinical changes are happening in your 40s and 50s. So just because your doctor said your labs are normal doesn't mean everything in your body is okay. So that's what made me write the book. And I have seen enough heart attacks and strokes in my practice, sometimes while I'm seeing the patient, that I felt this urgent need to share my experience and share with the community and the patients about what could they do to prevent that from happening.
Absolutely. That is so important. And I think that this is a perspective that most people never really get to hear. So it's incredible to hear it and have this new sense of prevention, especially from someone who is as knowledgeable as you. And like you said, for been doing this for over 20 years. So it is super important. And I think that a lot of people will gain so much from reading your book as well. And again, going back to how this is a perspective that most people don't hear frequently, that heart disease really begins long before the heart ever speaks. So, for anyone listening, if today's conversation made you rethink your own risks, take the next step, book your 15-minute discovery call with Dr. Rangi, and the link will be in the show notes with all the information that's needed. And remember, you can't always control your genetics, but you can lower the dose of stress, sugar, inflammation, and raise your life. Thank you again, Dr. Rangi. I cannot wait to talk to you soon. And for everyone listening, this is Lower the Dose, and we'll see you in the next episode.